Picture two brain scans, side by side. Both belong to women in their late 70s. Both show visible damage on the imaging. Both women have been struggling with memory, with confusion, with word-finding difficulty severe enough that their families brought them to a memory clinic, worried about dementia. One of these women has Alzheimer's disease. The other has Sjogren syndrome quietly attacking small blood vessels in her brain. And here's the detail that should genuinely stop you. With the right treatment, one of these women's memory scores actually improved over the following 2 years. The others continued to decline. Same symptoms. Same worried family. Same initial diagnosis of probable dementia. Completely different disease, completely different biology, and completely different outcome, once someone actually looked closely enough to tell them apart. Today we are going inside both of these brains, side by side, to understand exactly how Sjogren's changes the brain, how that compares to classic dementia, and why getting this distinction right can be the difference between watching someone decline and watching someone genuinely improve. I want to be upfront about the scale of this comparison before we go further, because I think precision matters enormously for a topic this sensitive. This isn't a video claiming Sjogren's is secretly a leading cause of dementia, or that every case of memory loss deserves a Sjogren's workup. It's a video about a specific, narrower, and genuinely important finding, that a real, documented subset of what gets labeled dementia in older patients may actually be a different, more treatable process entirely, hiding underneath a label that usually implies a one-way, irreversible decline. That distinction is worth 10 minutes of careful attention, precisely because of how much it could change for the specific patients it applies to. If you keep leaving appointments remembering symptoms you forgot to mention, I made a Sjogren symptom map to help you track the full pattern. Comment symptom map, and I'll send it to you. Let's start with what most people think dementia means, because I think the popular understanding of it is actually a big part of why this distinction gets missed so often. Most people picture Alzheimer's disease specifically when they hear the word dementia, a slow, steady, essentially one-way decline, driven by abnormal proteins called amyloid plaques and tau tangles gradually accumulating and killing brain cells, starting typically in memory-related structures like the hippocampus and spreading outward over years. This is a real, well-documented, progressive neurodegenerative process, and once it's underway, current medicine can slow it in some cases, but cannot meaningfully reverse the damage that's already occurred. Think of the classic Alzheimer's brain almost like a library slowly flooding, one shelf at a time, from a leak that never gets fixed. The books, the memories, the neural connections, get damaged permanently as the water reaches them. You can eventually stop the leak, or slow it considerably with the right intervention, but the books that have already been ruined don't dry out and become readable again. That's the fundamental, frustrating reality of neurodegenerative dementia as we currently understand and treat it. Now let's build the second brain, the Sjogren's brain, piece by piece, because the mechanism is genuinely different, and understanding that difference is the entire point of this video. Sjogren's can affect the central nervous system in a documented, if uncommon, subset of patients. Research estimates put central nervous system involvement at somewhere around 20% of Sjogren's patients overall, with broader neurological manifestations, including both central and peripheral nervous system effects, appearing in a wider range depending on how carefully researchers go looking for it. The specific mechanism driving central nervous system involvement most often traces back to something called angiitis, inflammation of small blood vessels within the brain itself. Remember from our video on why this disease is genuinely dangerous, Sjogren's involves immune complexes circulating through the bloodstream and depositing in blood vessel walls throughout the body. When that deposition happens specifically in the small vessels supplying the brain, it triggers local inflammation, restricts blood flow to the surrounding tissue, and over time, can produce visible damage on brain imaging called white matter lesions, areas where that chronic, restricted blood flow has damaged the brain's white matter, the tissue responsible for relaying signals between different brain regions. If the Alzheimer's brain is a slowly flooding library, think of the Sjogren's brain more like a city's water supply system where specific pipes have become inflamed and partially blocked, restricting water flow to certain neighborhoods. Some neighborhoods might be running on a persistent trickle rather than a full supply, functioning poorly, showing real signs of distress, but the buildings themselves, the actual brain tissue, aren't necessarily destroyed the way flooded library books are ruined. Clear the blockage, calm the inflammation in those pipes, and in at least some cases, full water flow, full function, can genuinely be restored to a neighborhood that had been struggling. That's the fundamental mechanistic difference driving why one of these processes can sometimes be reversed with treatment while the other, currently, cannot. This is a fundamentally different mechanism from Alzheimer's protein accumulation. Alzheimer's is, at its core, a problem of abnormal proteins damaging neurons directly. Sjogren's related cognitive impairment is, in its most common documented form, a problem of blood vessel inflammation restricting blood flow to brain tissue, causing damage through a vascular route rather than a direct neurodegenerative one. Same end result on the surface: memory problems, confusion, cognitive decline, completely different biological story underneath. If that distinction just reframes something for you, hold on to it, because it's about to explain something genuinely important about outcomes. Let's look at the actual research on how often this happens and how it's typically missed. One detailed study following patients with primary Sjogren syndrome found cognitive disorders in 60% of the patients studied, and remarkably, 5 of the 25 patients in that specific study met full criteria for dementia, not just mild cognitive impairment. For context, that same study compared these patients against a group with multiple sclerosis, another disease well known for causing real, sometimes significant cognitive impairment, and the Sjogren's patients showed cognitive disorders at a rate not far off from the MS comparison group, 60% versus 76%. That comparison alone should recalibrate how seriously this deserves to be taken. Sjogren's related cognitive impairment isn't some vague, minor afterthought symptom. It's occurring at a rate approaching a disease that's widely and correctly understood to meaningfully affect cognition. The same study found a measurable correlation between the severity of cognitive impairment and the degree of white matter lesions visible on brain imaging, exactly what the vascular mechanism we just described would predict. Processing speed, attention, memory, and executive function were the specific cognitive domains most frequently affected, a pattern that maps closely onto the kind of damage vascular-driven white matter injury tends to produce. This specific cluster of affected domains is actually a meaningful clue in its own right. Alzheimer's disease classically shows a somewhat different early pattern, often starting with a more pronounced deficit in forming new long-term memory specifically, while vascular pattern cognitive impairment, the kind driven by blood flow disruption, tends to hit processing speed and executive function first and most prominently. A sharp neuropsychologist, looking closely at exactly which cognitive functions are struggling and which remain relatively preserved, can sometimes pick up on this distinction well before an antibody test ever gets ordered. Here's a detail from that same research that deserves real attention. The average duration of cognitive complaints in that study was 5.6 years, while the average duration of the underlying Sjogren's diagnosis was almost 16 years. That gap matters. It suggests cognitive symptoms often develop well into the disease course, sometimes appearing gradually enough, and being attributed easily enough to normal aging or general brain fog, that both patients and doctors miss connecting them back to Sjogren specifically until they've been present and worsening for years. Imagine the actual lived version of that gap. Someone managing their Sjogren's for over a decade, gradually noticing their thinking has gotten slower, their memory less reliable, quietly assuming it's simply what getting older feels like, or a natural extension of the brain fog they'd already been told is just part of having this disease, never realizing a distinct, more serious, and potentially more treatable process might have started layering on top of their baseline symptoms. Now let's look at the study I opened this video with, because it's genuinely one of the most important pieces of research on this entire topic. Researchers at a dedicated memory clinic, the kind of specialty clinic patients get referred to specifically for suspected dementia workups, screened everyone coming through for Sjogren's-related antibodies alongside their standard dementia evaluation. Sjogren syndrome accounted for 7.5% of all the cognitive decline cases seen at that clinic. These patients showed a specific, recognizable imaging pattern: subcortical white matter lesions paired with asymmetric hypoperfusion, meaning uneven, patchy areas of reduced blood flow visible on specialized brain imaging, exactly consistent with the small vessel, immune complex-driven mechanism we've been describing. I want to emphasize how significant that 7.5% figure actually is, in context. This wasn't a study of Sjogren's patients being checked for cognitive problems. That framing might make you expect an elevated number, since researchers already knew what they were looking for. This was the reverse: an unselected population of patients coming into a memory clinic for garden-variety suspected dementia workups, most of whom had no reason to suspect Sjogren specifically, and testing everyone anyway. finding that roughly 1 in 13 of those patients actually had Sjogren's driving their cognitive decline suggests this isn't a vanishingly rare curiosity. It's a meaningful, underdiagnosed slice of the broader unexplained cognitive decline in older adults population, hiding in plain sight simply because nobody thought to test for it. And then comes the finding that I think should be genuinely major news to anyone managing this disease, or caring for someone who is. 12 of these patients were treated specifically for their Sjogren's related cognitive decline, and their memory scores, measured on a standard cognitive test, significantly improved over a median follow-up of about 2 years. Meanwhile, the patients in that same memory clinic who did not have Sjogren's, presumably including a meaningful number with classic neurodegenerative dementia, continued to decline over that same follow-up period, as would be expected with Alzheimer's disease or similar progressive neurodegenerative conditions. Let's actually look at the specific numbers, because I think the contrast is more powerful stated plainly than described in general terms. The treated Sjogren's patients' standard cognitive test scores rose to a median of 26 after treatment. The comparison group of patients without Sjogren's, tracked over that same period, saw their scores decline to a median of 22. On the same test, using the same scale, over a comparable stretch of time, one group of patients got measurably better and the other group got measurably worse. That's not a subtle statistical footnote. That's about as clean and dramatic a real-world contrast as clinical research on cognitive decline tends to produce, and it's exactly the kind of finding that should be shaping how memory clinics approach their intake process everywhere, not just at the specific clinic that happened to run this particular study. I want you to really sit with that comparison, because it's the whole reason I wanted to make this video in the first place. A meaningful subset of what looks, on the surface, exactly like dementia, memory loss, confusion, cognitive decline severe enough to bring someone to a specialized memory clinic, may actually be a treatable, and in some documented cases, genuinely reversible, complication of Sjogren's-related blood vessel inflammation, rather than an irreversible neurodegenerative disease. That is an enormous distinction, and it hinges entirely on someone thinking to test for it in the first place. Let's talk about why this specific distinction gets missed so often, because I think the answer says something important about how specialized modern medicine has become. A patient presenting with memory loss and confusion at 75 is overwhelmingly likely to be evaluated through a dementia-focused lens from the very first appointment. Cognitive testing, brain imaging looked at specifically for Alzheimer's pattern atrophy, discussion of dementia staging and progression. Testing for Sjogren-specific antibodies isn't automatically part of a standard dementia workup, because Sjogren's is, correctly, understood to be a comparatively uncommon cause of cognitive decline relative to Alzheimer's or vascular dementia from more typical causes like long-standing high blood pressure or diabetes. The memory clinic study we just discussed only caught these 7.5% of cases because researchers specifically built Sjogren's antibody testing into their protocol for everyone coming through the door, regardless of whether classic dry eyes or dry mouth symptoms were present. Most memory clinics don't do this routinely, which means, in a lot of clinical settings, this exact treatable cause of cognitive decline can be walking straight past unrecognized, folded into a general dementia, cause unclear diagnosis. There's a structural reason this gap persists, too, worth naming plainly. Geriatricians and neurologists running memory clinics are, understandably, experts in neurodegenerative disease, not necessarily in the finer points of autoimmune serology. Rheumatologists, meanwhile, are experts in exactly that serology, but rarely see patients who present primarily with memory loss rather than joint pain or dryness. Each specialist is excellent within their own lane, and this specific condition sits squarely in the gap between those lanes, a rheumatologic disease that manifests through a neurological symptom, evaluated overwhelmingly by neurology-focused clinicians who aren't necessarily trained to reach for a rheumatologic antibody panel as part of a standard workup. There's another wrinkle worth mentioning, one that makes this even trickier to catch. Central nervous system involvement in Sjogren's frequently precedes the classic diagnosis entirely, or occurs in patients who never develop prominent dry eyes and dry mouth at all. Some documented cases show neuropsychological symptoms as literally the first sign of the disease anyone notices, arriving before any of the sicker symptoms most doctors are trained to look for as the entry point into a Sjogren's workup. That means a purely symptom checklist approach. Does this patient have dry eyes and dry mouth? If not, probably not Sjogren's, can miss exactly the population where cognitive involvement shows up earliest and most prominently. Picture an elderly patient arriving at a memory clinic with no complaints of dryness whatsoever, simply memory loss and confusion. Under a symptom checklist approach, Sjogren's would likely never even enter the list of possibilities being considered, despite being, for that specific patient, potentially the entire underlying cause. Now, I want to add an important layer of nuance here, because a comparison video like this one can easily oversimplify into Sjogren's cognitive decline is always reversible, Alzheimer's never is, and that's not quite the full picture either. A large nationwide cohort study comparing autoimmune rheumatic diseases broadly, including rheumatoid arthritis, lupus, and Sjogren's, found a modestly elevated overall dementia risk associated with these conditions, with a hazard ratio around 1.14 compared to the general population. That's a real, measurable increase in risk, not nothing, but it's also a comparatively modest one, nowhere near suggesting that most people with Sjogren's are headed toward dementia. For comparison, a hazard ratio of 1.14 means roughly a 14% relative increase in risk compared to the general population, a real signal worth taking seriously in aggregate research, but a long way from a dramatic, life-altering individual risk factor on the scale of, say, carrying a strong genetic predisposition to Alzheimer's. And within that elevated risk, researchers increasingly recognize that some portion represents this specific, more treatable vascular and inflammatory mechanism we've spent this video walking through, while another portion likely represents ordinary age-related neurodegenerative disease simply occurring, somewhat more often, in a population already dealing with chronic systemic inflammation, since chronic inflammation, independent of any specific autoimmune diagnosis, is itself an established general risk factor for cognitive decline with aging. Researchers studying dementia risk broadly have noted that late-life brain changes are rarely caused by a single, pure mechanism in any patient. A mix of classic Alzheimer's pathology, vascular changes, and general inflammatory burden frequently coexist in the same aging brain, which means even within an individual Sjogren's patient's cognitive decline, there may be some contribution from more than one mechanism simultaneously, not a purely either-or picture. So the honest, complete picture looks like this. Sjogren's carries a modestly elevated overall dementia risk, and tucked inside that elevated risk is a specific, mechanistically distinct, and, critically, more treatable subtype, driven by small vessel inflammation rather than classic neurodegeneration, that a properly informed workup can identify and, in a meaningful number of documented cases, meaningfully improve with treatment. Let's talk about what treatment actually looks like for this specific subtype, because that's where a lot of the hope in this story lives. Since the underlying mechanism is inflammatory and vascular rather than a direct protein-driven neurodegenerative process, treatment generally targets calming that underlying immune activity, the same general category of immunosuppressive and immune-modulating treatments used for other serious Sjogren's complications, tailored to the individual patient's presentation and severity. This is fundamentally different from Alzheimer's treatment, which currently focuses on slowing progression or, with newer medications, targeting amyloid protein directly, rather than calming an active inflammatory process, because Alzheimer's simply doesn't have that same inflammatory, reversible mechanism driving it. It's worth being specific about why this treatment approach can work at all, mechanistically. If cognitive impairment is being driven primarily by restricted blood flow from inflamed vessels, our city water pipes analogy from earlier, then calming that vessel inflammation can restore more normal blood flow to brain tissue that was struggling but not yet permanently destroyed. Neurons that were functioning poorly due to chronically inadequate blood supply, rather than neurons that have already died, retain the potential to recover function once adequate blood flow is restored. That's the biological window this treatment approach is working within, and it's a fundamentally different window than the one available in classic neurodegenerative disease, where the neurons themselves, not just their blood supply, have already been damaged by protein accumulation. I want to be careful and precise here, because hope shouldn't tip over into overpromising. Not every case of Sjogren's related cognitive decline improves with treatment, and the research we've discussed today comes from relatively small patient groups, not massive, definitive trials. Some patients in these studies had extensive white matter damage that had likely accumulated over years, and damage that severe may not be fully reversible even with appropriate treatment, the same way a limb can lose function permanently if circulation is cut off for long enough before treatment begins. Earlier identification, before extensive irreversible damage accumulates, appears to matter considerably for how much genuine improvement is possible, which is exactly why the distinction we've spent this whole video building matters so much in practice, not just in theory. Let's bring this to something practical, because I don't want to leave you with just a fascinating research comparison and no actionable takeaway. If you have Sjogren's and you're noticing new or worsening memory problems, confusion, or word-finding difficulty, genuinely new changes, not the more common, generally milder brain fog most Sjogren's patients live with day to day, this is worth raising directly with your rheumatologist, specifically asking whether central nervous system involvement should be evaluated with brain imaging. This isn't a suggestion to panic over ordinary Sjogren's brain fog, which the vast majority of patients experience without it ever progressing to this more serious category. It's specifically about newer, more significant changes that feel different from your usual baseline. If you're supporting a family member who's been given a dementia diagnosis, and they also carry a Sjogren's diagnosis, or even significant undiagnosed dryness symptoms alongside their cognitive decline, it's worth asking their treating physician directly whether Sjogren-specific antibody testing was included in their workup. As we've covered today, this isn't automatically part of a standard dementia evaluation, and asking the question directly is exactly the kind of advocacy that could, in a small but real number of cases, uncover the more treatable version of this story instead of the fixed, progressive one. I want to give you the exact, specific language worth using in that conversation, because vague questions tend to get vague answers. Something like, has SSA and SSB antibody testing been done as part of this workup, and given some dryness symptoms, could Sjogren's-related central nervous system involvement be contributing here? Is specific enough to prompt a real, substantive answer, rather than a general reassurance that we've run a thorough workup. If the answer is that this hasn't specifically been considered, that's a completely reasonable moment to request a rheumatology referral or consultation, specifically to rule this in or out before accepting a final diagnosis of irreversible dementia. I'd also gently encourage bringing a written symptom timeline to that conversation if at all possible. When did cognitive changes start? Whether any dryness symptoms preceded or accompanied them, whether the decline has felt steady or come in more distinct episodes. Sjogren's-related central nervous system involvement, remember, often shows a more episodic, fluctuating pattern rather than the smooth, steady decline more typical of classic neurodegenerative disease, and having that pattern clearly laid out on paper can meaningfully help a specialist recognize which story they might actually be looking at. Let's clear up a few myths before we close this out, because a comparison video like this one can understandably generate some confusion if left unaddressed. Myth: if you have Sjogren's, you're at serious risk of developing dementia. Reality: the actual elevated risk found in large studies is modest, and the overwhelming majority of Sjogren's patients never develop dementia of any kind. What we've covered today explains a real, documented, but comparatively uncommon complication, not the typical course of this disease. Myth: Sjogren's-related cognitive decline and Alzheimer's disease are basically the same thing with different names. Reality: as we've spent this entire video establishing, they arise through genuinely different mechanisms, vascular and inflammatory in one case, protein-driven neurodegeneration in the other, and that mechanistic difference is exactly why one can sometimes improve with treatment while the other, with current medicine, generally cannot be reversed once established. Myth: ordinary Sjogren's brain fog is an early warning sign of this more serious complication. Reality: the vast majority of Sjogren's-related brain fog, the kind covered in our video on the hidden burden of this disease, is a separate, far more common, and far less severe phenomenon than the central nervous system vasculitis we've discussed today. Most people living with everyday Sjogren's brain fog will never develop this more serious complication. Here's what I want you walking away with. The brain, when it's struggling, doesn't announce which disease is behind the struggle. Two people can present with strikingly similar memory loss and confusion, and be living with fundamentally different diseases, following fundamentally different paths, capable of fundamentally different outcomes with treatment. Knowing that distinction exists, knowing that some memory loss has a treatable, vascular, inflammatory story underneath it, rather than an irreversible neurodegenerative one, is exactly the kind of knowledge that can turn a resigned, there's nothing more to be done, into an actual, evidence-based reason to look closer. I think about those two brain scans I open this video with often, honestly, because I think they capture something important about the limits of how medicine sometimes categorizes illness. Dementia gets used, casually, as if it's a single destination rather than a symptom that multiple, genuinely different roads can lead to. Some of those roads, like Alzheimer's, currently only go one direction. Others, like the one we've spent this entire video walking through, sometimes have an off-ramp, if someone thinks to look for it in time. The word dementia alone can't tell you which road a specific patient is actually on. Only a careful, curious, willing to test for the less obvious cause workup can do that. If this gave you a new question to bring to a doctor's appointment, for yourself or for someone you love, that's exactly what this video was built to do. Go back and watch our explainer on why Sjogren's is dangerous at the mechanistic level if you want the fuller picture of how that same immune complex process we discussed today shows up throughout the rest of the body, not just the brain. Type brains in the comments if this comparison helps something click for you, or if there's someone in your life this distinction might actually matter for. Not every memory that fades is fading for the same reason. Sometimes, that difference is everything. I'll see you in the next one.